of why we use PARP inhibitors. To use as a scaffold, but not to really present something with a lot of clinical trial information with the newest trial designs or so, but really something very practical. Because really PARP inhibitors have taught us in the prostate cancer field that molecular testing is important, and what we do now in PARP inhibitors hopefully will be applied at some point in the not so distant future for other treatments as well. And I have a few household slides to start with. So this program developed by the COA was sponsored by Merck and AstraZeneca, who are the companies that distribute the olaparib, one PARP inhibitor approved for prostate cancer in Canada. If you need to document CMEs, you have the option to do so. And this is the faculty that developed the program. Dr. Saad, he's a urologist, but in essence works like a urologist and a medical oncologist. And he's really one of the key persons for prostate cancer care in Canada. Then Dr. Fleschler, who's a urologist at the Princess Margaret, doesn't need the introduction. Michael Kolinsky, who is a medical oncologist from the Cross Cancer Center in Edmonton, who did a fellowship with Dr. De Bono, who was one of the key figures to develop PARP inhibitors in prostate cancer, and Dr. Kapoor, who's a urologist in McMaster's. And the four clinicians were complemented by Mike Provine, who's a clinical pharmacist. I want to disclose my affiliations with both AstraZeneca and Merck, primarily through clinical trials, but then also through consulting. And as a member of the Department of Medicine, I would like to acknowledge the land we live, work, and study on, and we hold to equity, diversity, and inclusion. So what I would like to do is that I would like to use the four modules of this program to speak about DNA damage response in very general terms, more from a biological point of view. Then about genetic testing. This is probably the most important part of today's presentation. I will review some clinical data about PARP inhibitors. And then maybe equally important as the second module is module 4 about some of the practical aspects of using PARP inhibitors. We'll start with a DNA damage response. DNA damage is a factor of life. Each day, more than 1,000 mutations happen either through, for instance, UV light, through ionizing radiation, or just as part of cell replication. And there's three scenarios. If the DNA repair is perfectly corrected, then nothing happens. If no DNA repair takes place, or the DNA repair is not sufficient, then these cells often would die. But really the most influential events are DNA repair defects, or DNA damage that cannot be properly repaired and will be propagated in cells and eventually can lead to diseases such as cancer. And there's quite a bit of energy each day that cells put into maintaining the integrity of their genetic information, with a number of processes that can repair DNA damage. And I want to focus here, for the sake of this presentation, on single-strand break repair with one of the key enzymes being PARP, and on homologous recombination repair, which is important for double-strand DNA breaks. And you see one of the enzymes involved are BRCA2, which stands for breast cancer 2, BRCA1, ATM, and PALP2. And what PARP really does is that PARP is a molecule that is directed to sites of DNA damage, and it then adds poly-ADP, polyadenosine phosphate ribose polymers to the area of the DNA damage, but also to enzymes that are recruited and that will make up a DNA repair machinery. And if PARP is inhibited, we have molecules that can do that, such as, for instance, olaparib, as I mentioned before. DNA repair does not take place in a proper way, and these single-strand breaks typically then can degrade into double-strand breaks, and that happens, for instance, during a ensuing replication process. So how can cells deal with double-strand breaks? Single-strand breaks are relatively easy to repair, and it's also relatively easy to maintain the fidelity of the genetic information, but double-strand breaks are difficult to repair. And there's a process called non-homologous end joining, which in essence means that at the area of the break, the ends are cut off and stitched together, and that obviously puts the cells at the high risk of coming up with deletions and other DNA changes that will impact potentially the function of genes. There is another process called homologous recombination that truly tries to re-establish the genetic information, and you see that the important genes are, as I mentioned before, BRCA1, BRCA2, BALP2. So how can we exploit that for cancer treatment? And it's not just in prostate cancer. PARP inhibitors also used, for instance, in breast cancer, ovarian cancer, and pancreatic cancer. If you use a PARP inhibitor, it will increase the risk of single-strand breaks that can degrade into double-strand breaks. And this is not an issue for cells that have homologous recombination repair in place, but it becomes an issue for cells that are deficient in homologous recombination repair. And quite a few of prostate cancer patients have cancer cells that are completely insufficient when it comes to homologous recombination repair. And these cells will then die off, which also means that the cancer cells are highly sensitive to PARP inhibitors, whereas the normal cells are able to repair these DNA damages. And this explains why PARP inhibitors overall have relatively limited side effects, but are very specific events to come to eliminate cancer cells. And I mentioned before that PARP inhibitors are used in other disease conditions. Prostate cancer just was added recently, but you see that this is a type of a drug that has been developed since more than 20 years. And the drugs that are being tested in prostate cancer are olaparib, which is also approved in Canada for men with defects in BRCA1, BRCA2, or ATM, that have been treated previously with, for instance, olaparib or enzalutamide, agents that affect the androgen receptor signaling pathway. Rucaparib is only approved in the United States, and the company seems not to be filing with Health Canada. And talazoparib is a drug that is developed by Pfizer, and they have pulled the trigger on using talazoparib as a monotherapy. With all these drugs that are listed here have been tested in one way or the other as monotherapies, and I will come to this during my third segment. There is, though, an alternative to using PARP inhibitors. This is obviously old-fashioned. It's old-fashioned chemotherapy when you use platinum compounds, for instance, cisplatin or carboplatinum. These are agents that can introduce double strand DNA breaks, and thus can also be quite helpful in patients with homologous recombination defect cancers, as you can see on the right side of this panel here. So to briefly summarize, there's numerous ways of how DNA damage can be repaired. There's two different types of damage in very simple terms: single-strand breaks and double-strand breaks. But really, defects in homologous recombination repair sensitizes tumor cells to PARP inhibitors, to platinum agents, and potentially also to radiation therapy. And that might include, in the case of prostate cancer, radium-223 and lutetium PSMA-617, which are somehow internal versions of radiation therapy, or radiation therapy that is administered as an intravenous treatment. Now, with the first segment, I somehow laid out the foundation to show you in the next few minutes why it's really important to do more and more genetic testing to identify patients that might benefit from PARP inhibitors. But this also has repercussions, not just for the patient, actually has also potential repercussions for the other family members as well. And I want to start with this slide here. this shows you that the risk of having prostate cancer is highly variable. When you, for instance, compare South Central Asia and you compare North America, the risk is different by a factor of around 25-fold. And in places like Guadeloupe, the risk is exceedingly high. And part of the risk is definitely dependent on the age distribution in a society, and obviously in elderly societies such as North American societies, the risk is high with prostate cancer. It's a disease of the elderly. Part of it might have to do with life circumstances, with diet, but a big part of it seems also to be related to genetics. And we know that from twin studies that were done in Nordic countries, in Scandinavian countries, and prostate cancer is amongst the cancers with the highest rate of heritability. And we assume that close to 60% of the risk of developing prostate cancer is driven by genetics. And until 5-6 years ago, we actually did not really understand what really the drivers were of this genetic risk. There were a lot of studies done identifying single nucleotide polymorphisms, which are small genetic changes that are very individual and that can allow to track down certain traits, such as, for instance, having a higher risk of having prostate cancer. And for prostate cancer, there were more than 250 of these SNPs identified, but each SNP only contributes at a very small incremental amount to the risk of developing prostate cancer. And none of these SNPs could be used for any treatment decisions, because typically it's not entirely clear why a certain SNP is related functionally to prostate carcinogenesis. But this really changed 5-6 years ago with, amongst others, this publication here that showed that around 10% of patients with metastatic castration-resistant prostate cancer have germline mutations involving DNA repair genes. And I will come to the term germline in the next few slides. And when you see on the panel on the left, really the large majority of these changes are related to BRCA2, ATM, CHEK2, and BRCA1. And we assume that around 5% of patients with metastatic CRPC have germline changes in BRCA2, which is important for therapeutic considerations I will show you later on. But it has another importance. When men are carriers of BRCA1 or BRCA2, they have a higher risk of developing prostate cancer, and the increase is actually quite significant. They have a higher risk of developing prostate cancer at an earlier age. They also have an increased risk of developing breast cancer, pancreatic cancer, and melanomas. And they typically come from families with indication that the risk of cancer might increase. The second important aspect is that unfortunately, patients that have germline changes to BRCA1 or BRCA2 also tend to have more aggressive disease. They are diagnosed with higher Gleason scores, which is a pathological grading of the aggressiveness of cancer. They often have already lymph node metastasis or distant metastasis diagnosis. They definitely have a higher risk of developing metastasis, even when they're diagnosed without metastasis. They have a higher risk of failing curative treatment attempts, and they have a higher risk of dying eventually from prostate cancer. But unfortunately, everything that we know about BRCA1, BRCA2, and also ATM to a certain extent is really based on studies that are done primarily with white Anglo-Saxons and Protestant patients. And we know that, for instance, African Americans have a higher risk of dying from prostate cancer, of developing prostate cancer, but the genetics of African Americans is by far less well understood. So there's still a lot of work that needs to be done. Now, I mentioned before that I will introduce the term germline as opposed to somatic. So germline means that somebody is born with a genetic defect, which typically affects one allele, because everybody has 2 copies of a certain gene. And over time, this defect might actually then be complemented by another defect in the same gene. And why this happens in, for instance, BRCA2 and specifically in prostate cells is not so clear. But in essence, it needs another genetic event, another DNA damage that leads to the fact that both copies of the gene will be affected. And if it's BRCA2, then these cells will become insufficient when it comes to homologous recombination repair. Another way to develop prostate cancer is to have somatic changes. Somatic changes means that somebody is born without a genetic defect in the BRCA gene, but acquires a first mutation at some point, and then later in life acquires a second mutation. And the difference between the two scenarios, germline and somatic, is that patients with somatic changes to BRCA2, they still have more aggressive prostate cancer, but they are usually diagnosed at a similar age to other men with prostate cancer. And on the other hand, whether the defect started as a germline defect or as a somatic defect, if both copies of the BRCA genes are deficient, then these cancers are highly sensitive to PARP inhibitors. So when you then really look at the numbers, when you take somatic changes and the germline changes, around 20% of patients with prostate cancer have DNA repair defects. And these are mostly defects related to homologous recombination repair, but can also be defects related to other repair mechanisms that, for instance, can sensitize patients to the use of immunotherapeutics, but this is not the part of my presentation today. So this somehow sets the foundation for why we might be interested in doing genetic testing. It might provide some prognostic information. It might also provide information about the familial risk of having prostate cancer. And obviously, in patients that have established metastatic prostate cancer, it will identify patients as potential candidates for PARP inhibitors. Now, there's different types of genetic testing or molecular testing, depending on what source of tissue you use. And so if you, for instance, use cancer tissue, you can do both. You can do germline testing, you can do somatic testing. If you take, for instance, a blood sample, if you take a saliva or you obtain a buccal swab, then you can only do germline testing. And if you obtain plasma and isolate the circulating tumor DNA, under certain circumstances, you can do both somatic testing and also germline testing as well. So the material matters. And the materials also matter in terms of how easy it is to do the testing. Tissue testing is the most established, but it's sometimes difficult to identify the tissue. Sometimes no tissue is anymore available. And unfortunately, tissue testing fails in around 30% of patients. When it comes to ctDNA analysis, it's very easy to get a blood sample, but the testing is more complex. It's also financially more challenging. It's more expensive than tissue testing. And there's a certain risk of false negatives or false positives. And when it comes to germline testing, again, buccal swabs, blood, saliva are very easy to obtain. And the testing is quite straightforward. But unfortunately, from a therapeutic perspective, if you only do germline testing, then you miss 50% of patients that could be candidates for the PARP inhibitors. Now, for the next few minutes, I want to speak about germline testing. And in Ontario, we're fortunate enough to have a program in place since 2021, where we can offer patients with a metastatic prostate cancer germline testing. There's also patients with certain high-risk localized cancers that would be candidates for germline testing, or patients with certain family history constellations, which are listed down in more detail here. But in essence, all the patients that Dr. Smoracevic and myself see are metastatic and are candidates for germline testing. The way how we do it is we apply the mainstreaming model. I can admit that until 2-3 years ago, I had no clue what mainstreaming really means. And sometimes I still have the impression that I don't fully understand what it means. But in essence, what it says is that As an oncologist, we will approach patients, we explain them the reason of doing the genetic testing, a little bit how it works. We just obtain easy blood samples that it takes usually 2 to 3 months before we have the results, and then also what they can expect from the results. So it's really the oncologist, and this can be medical oncologists, can also be radiation oncologists, neurologists that initiate the germline testing. The genetics counseling team then gets involved to complement or actually to obtain a really detailed family history. And they're also getting involved when it comes to discussing the results of the germline testing with patients. And in essence, there's 3 scenarios: either the changes that are detected, and in Ontario, currently we have a 19 gene panel that is used for prostate cancer patients. So if there's any pathogenic changes in any of these 19 genes, then typically the genetic counseling team really will speak with the patient and then also start to inquire about other family members. And that probably applies to around 5 to 10% of patients that we test. The majority of patients will have no genetic changes that would put them at the risk of developing cancer or passing the cancer on to other family members. And then there's a small group of patients, maybe 5 to 10%, that have changes that are hard to classify. It's not entirely clear whether they have any meaning or not when it comes to cancer. And really the important part of the germline testing that goes beyond the patient is that it has implications for family members. As I mentioned before, that when a patient, for instance, has a BRCA2 alteration that is in germline, there is a 50% risk that he might pass this on to his children. There's also a risk in his sisters and brothers that they might have the same changes. And it is important to understand that it's not just about prostate cancer, since these BRCA changes can also be the risk for breast cancer, ovarian cancer, pancreatic cancer. It really is about females and males in the families. And for me as a medical oncologist that treats prostate cancer patients, and this is unfortunately still an incurable condition today, this is maybe the only way that I could not cure patients or family members from cancer, but prevent them from becoming cancer patients eventually. Now, for the next 2-3 slides, I want to go back to somatic testing. So germline testing is relatively established already in Ontario. And in our case, for instance, the samples go to North York General Hospital. But for somatic testing, we are not yet where I would like to be. We can do now tissue testing, and this is a process called reflex testing. So everybody, in essence, that is diagnosed with prostate cancer these days, and the biopsy goes to our pathology department, there will be consideration of doing testing of changes to BRCA1, BRCA2, ATM, and the PARP2. And you see that Sunnybrook is just one of the pathology centers across the province that have the capability of doing this type of testing. Where we still lack a little bit is testing based on ctDNA, plasma-based testing. We can do that at the moment as part of the Distinction program, which is sponsored by AstraZeneca as a way to complement their access program for olaparib. And I have experienced myself with, together with my patients, that ctDNA testing is more complex and often raises more questions than it really gives answers. So often it has to be complemented by tissue-based testing anyhow. And unfortunately, the Distinction program is a program that is limited in time, and we do not have yet the capability of doing ctDNA testing here at Sunnybrook. So we'll see how this will work out in the long run. So to summarize, we have multiple ways of doing molecular testing, and really it depends on the question you want to answer, maybe which type of tissue source you use and which type of testing you order. And unfortunately, And there is a lot of disparity across Canada and also across Ontario when it comes to access to this type of testing, these type of tests. And I think Ontario overall actually is in a very fortunate position that we have relatively easy access, at least to germline testing. Now, this brings me to the model 3, which is relatively brief. This is about clinical information about using PARP inhibitors. A first wave of PARP inhibitor trials were done as monotherapy trials, so just using the PARP inhibitor alone. And we were, for instance, part of the PROfound study. And I will show a little bit more that about PROfound. This PROfound is really the study that is at the base of healthcare approval of olaparib, and is the most influential study when it comes to PARP inhibitor use of prostate cancer patients to date. In PROfound, patients were selected if they had prior treatment with a ARAT, with an androgen receptor axis target agent such as abiraterone and enzalutamide, and they could have had previous chemotherapy with a taxane. And the study was designed in a way that they subgroup patients into cohort A with changes to BRCA1, BRCA2, or ATM, and then a cohort B of changes to other DNA repair genes that are less frequently found to be mutated in cancer patients, in prostate cancer patients. And the testing was done based on tissue. So they did some analysis also about circulating tumor DNA, but really for study purposes, the testing was done based on tissue. And patients that tested positive were then slotted into cohort A or cohort B and then randomized 2-to-1 to get olaparib, or what was considered the physician's choice between enzalutamide or abiraterone. And patients that were randomized to enzalutamide or abiraterone had the option of crossing over to olaparib upon progression. And as you can see here, all patients had had either enzalutamide or abiraterone, and actually around 20% of patients had had both medications, and around 65% of patients had had at least one taxane. And it's of no surprise that when you use enzalutamide or abiraterone in a patient population, or it has been highly exposed to the agents, that it doesn't take long before these cancers start to progress. And you see that on the left panel in the gray survival PFS curve. But when you use olaparib, you actually can increase the time to radiologic progression by around 4 months to up to 8 months as a median. And despite crossover, this study also showed that the patients in cohort A, so these are really the patients with suspected defects in homologous recombination repair, have a survival benefit which is in the order of around 4.5 months. And if you try statistically to account for the crossover of some of these patients in the control arm, then you see on the right side that patients that were in the control arm lived for another around 12 months or so once they were accrued for the study. But patients in the olaparib arm lived for up to 18 months, so a significant increase in overall survival. Now, the next round of trials that is currently going on and just being reported are combination trials. And obviously the idea behind combination trials is that you can make these drugs, these PARP inhibitors, useful drugs, not just for patients with certain genetic features, but potentially all-comer patients. And 2 studies have been already reported, the PROPEL and Magnitude, with results that are to a certain extent maybe contradicting, but at least they seem to indicate that patients benefit from a combination of olaparib with abiraterone or another PARP inhibitor, niraparib with abiraterone. But these are complex studies. The data is still relatively mature, and we do not know whether combinations of a drug such as abiraterone with a PARP inhibitor really has a overall survival benefit. Thus far, the benefit is restricted to progression-free survival. So to briefly summarize, there's a number of drugs from the PARP inhibitor family that are being tested in prostate cancer. And thus far, all the studies that used PARP inhibitors and monotherapy in molecularly defined patients show they benefit when it comes particularly to patients with alterations of BRCA1 or BRCA2. And the combination trials, as I mentioned before, are quite immature, and only time will tell whether this is really a home run or not. And this brings me now to the last part of my presentation, which is really about speak about some of the practical aspects of using PARP inhibitors. Because PARP inhibitors are definitely drugs that are more complex when it comes to the side effect management compared to, for instance, abiraterone or enzalutamide. And you might tell me that I'm biased, but I think that for most part, these are drugs that belong into the hands of a medical oncologist, and rather so than maybe, for instance, a urologist or a radiation oncologist. This is different when it comes to olaparib and enzalutamide, which are really drugs that, abiraterone and enzalutamide, which are really drugs that are commonly used now by urologists and radiation oncologists as well. And you can see here in this tornado plot that the use of PARP inhibitors, in this case olaparib, comes with an increased risk of side effects. And there's different types of side effects. The most common side effect is anemia, and anemia can be quite severe in around 20% of patients. At least at the beginning, many of these patients will have some gastrointestinal symptoms such as feeling nauseous, lack of appetite. Some patients might have diarrhea, some patients might also be constipated. But overall, these side effects can typically be managed with dose interruptions and then starting maybe at the lower dose. And it's very rare that really the drugs have to be completely discontinued. And I just have highlighted here the numbers for anemia, and that you see that those interruptions are definitely higher by a factor of 10 to 20-fold in olaparib patients. The risk of dose reductions is higher, but the number of patients that stop the treatment of side effects is less than 10%, which seems to be reasonable for a drug that I often describe to patients as a type of oral chemotherapy, somewhere in between abiraterone, enzalutamide, and taxane intravenous chemotherapy. We have a relatively good understanding of when we expect some of the side effects. As I mentioned before, nausea is actually something that might happen quite early. And in our case, our pharmacy dispenses olaparib together with an antiemetic so that patients early on can use an antiemetic. And often it's just a matter of a few weeks at the beginning before the nausea actually becomes less of a concern, and patients often then stop the antiemetic. The impact on appetite, fatigue might be early side effects as well. And for anemia, it usually takes a bit of time before it becomes a concern, but it also takes quite a while in some patients to actually fix it for making it happen for patients to use olaparib in the long run. And many patients use olaparib for more than 6 months overall. There is always a concern that if patients have a high degree of bone marrow infiltration of when they were treated with chemotherapy, that they might be at a higher risk of myelosuppressive side effects, such as anemia in the case of olaparib, but that seems not to be the case. So it seems to be a fairly safe drug, largely independent of when you use it, although preferentially, most oncologists probably would use it in patients that are chemotherapy naive. But there's also some uncommon side effects related to PARP inhibitors. One is, for instance, myelodysplastic syndrome, which is some kind of a precursor for acute myelogenous leukemia. This is relatively rare, probably happens in around 1% of patients, and this is something that is seen with all the PARP inhibitors, not just with olaparib. In the case of olaparib, there have been descriptions of pneumonitis, of also thromboembolic events, and in particular, the thromboembolic events are not just something uncommon that happens in maybe 5 to 10% of patients. They often detected as part of doing CT scans to follow up on cancer progress. And in this case, they often are not symptomatic, but they are consequential. These patients typically will then be started on anticoagulants. And then something that seems to be relatively unique to niraparib is that patients that get niraparib are at a quite high risk of hypertension. And in some patients, the hypertensions can be quite violent and can happen quite rapidly. So what do we do when it comes to anemia? First of all, you have to monitor, and typically our patients have blood counts done at least once every 4 weeks, in clinical studies even more often than this. If the hemoglobin goes below 80, they are considered for transfusion, but at the same time, you also have to count for other causes of anemia. Patients might have iron deficiency, they might be deficient in vitamin B12 and folic acid. And again, in some patients, bone marrow infiltration might matter nonetheless. And if, despite stopping a PARP inhibitor, the anemia continues to be a concern, then patients should be seen by hematologists to make sure that they don't suffer from a myelodysplastic syndrome. In terms of fatigue, these are some commonplace recommendations what to do. I'm not aware of any really great way of counteracting fatigue. You can use a certain medication. Sometimes we might use steroids for helping patients against fatigue. But in essence, it's really the aim should be, I think, to keep patients as active as possible. And if you can maintain a certain degree of activity, I think this is, in the long run, probably the best strategy, but it's sometimes easy said and not so easy done from a patient perspective. With respect to GI symptoms, I think we know how to treat diarrhea. Some patients might benefit from a proton pump inhibitor. And I mentioned before that, at least in our case, we usually prescribe antiemetics with the first prescription of PARP inhibitors so that patients can early on start with antiemetics and treat this accordingly. And then maybe the last thing I want to bring up is drug-drug interactions. PARP inhibitors are complex drugs. They have complex metabolism that are different between the drugs, because these drugs are also structurally quite different from each other. And I've highlighted here olaparib, which is metabolized by cytochrome 3A4. There's a typo on the slide, it's 3A4. And this is unfortunately one of the liver enzymes that is involved in the majority of medications, or in a large part of medications. And if patients take certain medications that interfere with the function of 3A4, this might make it sometimes difficult to use olaparib in a safe way, but also in an efficacious way. And this brings me to one of my last slides, just some very practical aspects with respect to olaparib, knowing that typically the rounds are attended also by nurses that see our patients. Olaparib is given at the dose of 300 milligram BID. It comes in 150 milligram tablets or in 100 milligram tablets. Patients that get this medication should continue with their LH-RH therapies. Patients should be advised that if they're not sure whether they took a dose or not, they rather should just leave it and start the next day. And there's also some recommendations here that they should not manipulate the drugs. It is important to avoid certain food items. I have one patient at the moment who is on olaparib now since more than 1 year, and more recently his hemoglobin actually came down quite dramatically to 56. And I found out only in hindsight that he had started to use grapefruit since around 2 months, and he took grapefruits at least 2 weeks, 2 times per week. So this might be an explanation why he became anemic, because grapefruits are expected to increase the circulating levels of olaparib. That might be the reason why he has no more toxicity. But to really summarize and to emphasize that, in my experience at least, and maybe Dr. Moracevic can comment on this as well, PARP inhibitors are relatively well-tolerated drugs, at least when used as monotherapies. Anemia is something that definitely happens, and prescribing physicians need to have the infrastructure and also the experience to deal with anemia. These patients need monitoring, very close monitoring actually, which is very similar to when we subject patients to intravenous chemotherapy. And there's rare side effects that physicians have to be aware of, such as, for instance, the myelodysplastic syndrome. Now, if we start to use PARP inhibitors at some point in the future, in combination with other medications, we might see more side effects, because drug-drug interactions between prostate cancer medications and PARP inhibitors might be quite common. And the more drugs you use, obviously, the higher the risk is of running into side effects issues overall. And I want to finish off with just some few personal thoughts. It's actually a good timing to speak about PARP inhibitors today, because I understand it's not yet official, but olaparib will be funded in Ontario relatively soon. We'll have access at the moment through an access program, but that will be replaced by an early access program from the Ministry of Health. It will be restricted to patients with documented BRCA1, BRCA2, or ATM aberrations, and that can be germline and or somatic. When it comes to some of the rarer mutations in genes that are only rarely affected in prostate cancer, such as, for instance, CHEK2 and others, I think we still have to learn whether PARP inhibitors are really a helpful tool. And at least for the time being, we do not have access to PARP inhibitors for these patients outside of clinical studies. And as always in cancer, at least in the prostate cancer field, whatever works, it will stop working at some point. Unfortunately, PARP inhibitors are not curative treatments for prostate cancer patients. I think the next big question that hopefully will be resolved anytime soon is that whether combination strategies will allow to use PARP inhibitors not just in patients with certain genetic features, but actually all comer patients when you, for instance, combine PARP inhibitors with abiraterone. And really, I want to emphasize the fact that PARP inhibitor therapy is a collaborative effort. It involves the genetic counseling team. It involves a molecular pathologist, pharmacists, nursing, and I might have forgotten other healthcare providers as well. So, but it's a really nice way of bringing people together, and I think we have benefited here at Odette to have had clinical studies with PARP inhibitors early on, and to have a great genetic counseling team. I think the question of molecular testing came up at the right time when PARP inhibitors really became more of a consideration for day-to-day practice. And these are complex drugs where we need a lot of input from pharmacists, and eventually nursing will be instrumental to make these treatments safe and tolerable for patients. And I hope that we can use the model that, or the models that we have established for PARP inhibitor therapy for future treatments to come that will also rely on molecular testing, so that we can actually build up from the current capacity to integrate new treatment modalities. And eventually, and I mentioned that to you before, this is maybe my only contribution to save patients from dying from cancer, in that with germline testing, we can hopefully not only identify other family members at risk of having cancer, but prevent them from becoming cancer patients. And with this, I think this is my last slide, and I think we can open the Q&A session.
Thank you, Urban, for that great overview. Lots of ground you covered in this presentation. So perhaps we'll open up the session to questions. So you can either enter your questions in the chat box and I can read them out, or alternatively, I suppose you could raise your hand and ask it. We have one question already from Dr. Loblaw here.